So this is where I'm really excited, because this is where America's cardiologist, Dr. Mohammed Allo, meets testosteronology. Okay.
All right.
Yeah. So we're going to debunk a lot of things within cardiology, because we hear people saying stuff cardiology related and they're not cardiologists at all. And so, as you like to say, cardiologist here. Okay. He is right here. Dr. Al, can you tell us who you are, even though a lot of people already know you?
So thanks for having me on. First of all, I'm super excited to be here. So my name is Dr. Mohammed Allo, like you said. I'm a cardiologist by training. I've been practicing cardiology 14, 15 years now, and medicine, before that, obviously. I'm also a certified personal trainer. I do bodybuilding. I lift weights. Andrew can attest to that. We've run into each other a couple times in Florida. But yeah, I lift weights. I'm all into the science behind, weightlifting, weight loss. I do obesity medicine too. So I'm very, very familiar with medical weight loss. And because I'm a certified personal trainer, weight loss, the good old fashioned way, calorie counting, macros, proteins, carbs, what have you. I also coach a lot of sports. Football season is over now. I coach football, and that's one of my favorite things to do. I've coached almost every youth sport you can imagine. Football is my favorite by far. That's the one that I played. A lot of people don't know this. I walked onto my Division I local college team and made it. Now, I was mainly a practice squad dummy, but still, I think that's an accomplishment.
You played college ball? I didn't know that.
Yeah. Absolutely. Just
really
and made the team. Obviously, I wasn't a starter. We had the guy that was the running back, our starting running back, ended up in the NFL and made a lot of money. Played for the Baltimore Ravens, Chester Taylor, and played for the Minnesota Vikings. But yeah, so there was not a lot of actual playing going on, but I was a practice squad dummy. It was a lot of fun. But when the medical kind of, classes got harder, I ended up having to get out of that and just kind of focus on studies when the courses got harder. Let's put it that way.
So what I really like about you is that you're not what I would consider, and I hang around cardiologists all day long, and you are not what I would consider a typical cardiologist. You're one of us at heart in a way, and the fact that you're a personal trainer too, and you understand dietetics and nutrition.
Well, and I play a lot of sports. I mean, up until, I played football the last time I played football was like 2 years ago. I coached football. I played tackle football, obviously, but no one my age wants to play tackle. I'd love to. But I play pickup, flag football. I coach football. I play basketball almost every week. Now, I did have a PCL, injury about 7-8 months ago. So I've had to lay off of that for a little bit. I tore my rotator cuff recently. I'm out of the sling now, but I've had to lay off the weightlifting and basketball for now. But yeah, I've been playing sports my whole life. Definitely, I don't know too many doctors that have played sports or do the bodybuilding. Some of my orthopedic friends do. You do see that a lot more in the orthopedic field. I have a number of orthopedic surgeons who are my friends who are also, into weightlifting and playing sports and all that kind of stuff. But yeah, you're right. You hang around cardiologists because that's your main job. And yeah, I'm pretty sure none of them are bodybuilders or lift weights or
no. And somehow with all that sports and extracurricular things you do outside of cardiology, you are the author of the new book that you did with Dr. Dayspring, Cholesterol Truths. And I really think that really needs to be highlighted, because right now there are so many myths right now when it comes to lipids. There it is right there. Okay. And a lot of myths right now that we have to really debunk, especially when it comes down to hormones. And every time I talk about lipids with Dr. O'Connor, he always says, well, Andrew, you're not a doctor. Well, guess what, Dr. O? I brought my big brother with me. Okay. And so, all right. So, on Testosteronology, we deal with a lot of things TRT related, because hormone therapy is becoming a cornerstone and it's infiltrating primary care. And the good thing and the bad thing is, the good thing that it helps a lot of men and women, but the bad thing is there are some inherent risks. And a lot of those risks we see are impacting the cardiovascular system. Okay. So let's deep dive into hormones and how this affects the cardiovascular system.
Yeah. So the main reason I wrote the book, and you're right, is mainly because there's so many myths around it. Like, I've been on social media, pretty hardcore for the last 2 or 3 years now. And it's like every day somebody says, well, statins lower your testosterone and statins do this to your brain and dementia and Alzheimer's. And doesn't your brain need cholesterol? And doesn't your nervous system need cholesterol? And doesn't this and doesn't that? People are asking all these questions. And obviously I published close to 3,500 videos now on every single one of these questions. People are like, well, doesn't your brain need cholesterol? There's at least 15 videos that I put out there on, yes, your brain needs cholesterol, but it makes its own cholesterol. The circulating cholesterol in your bloodstream does not cross the blood-brain barrier, and your brain does not need that cholesterol. But when you have too high cholesterol in your bloodstream, it plugs up the arteries going into your brain, just like everything else, and causes dementia, Alzheimer's, vascular dementia, all of that. And then people say, well, doesn't it lower your testosterone? And then I publish a bunch of studies and videos talking about those studies. And people are like, you know what? Can't you just make this into a book so we can sit down and hold it in our hands and put it on our coffee table or in our waiting room? A lot of these people are doctors, cardiologists. You're good at explaining things. Can you just explain, put this in a book so we can purchase it and buy it? So I enlisted the help of the world's greatest lipidologist. Lipidology means the study of lipids, actual cholesterol and lipoprotein metabolism, and what they do, so that people can't just say, well, he's just biased or he just made all this stuff up. This is literally the world's greatest lipidologist who's given 4,000 to 5,000 lectures across the world on lipidology and cholesterol, and has written multiple chapters of actual textbooks. My book is not a textbook. Anybody can pick it up and read it. You can attest to that, Andrew. I know you have one. But it's a book that anyone can pick up and read. It's written by someone who spends their day looking inside your arteries. That's literally my actual job, doing cardiology every day. And a lipid.
Keyword, his actual job is to look inside your arteries. This is his day job. Okay.
Right. So that's what I do for a living. And then Dr. Thomas Dayspring is a lipidologist. His job is to manage, people's lipids, cholesterol, and what have you, and publish about it. For a long period of his life after he, stopped practicing, he was mainly a researcher, and he would sit in a lab and, research and publish lectures and all that. And he traveled the world lecturing on lipids. So you've got two people who really know this topic inside out. The book is five. You've seen it, Andrew. It's 516 pages.
Yeah, but let me reiterate that for anybody who doesn't understand what he just said. He is the Navy SEAL. These are the Navy SEALs of arterial health. Dr. O'Connor, you're an endothelial guy. He wrote the book, literally. Okay, keep going. Sorry.
So thank you, Andrew. But it's 516 pages. It's over 800 studies, and it took almost 2 years to write. You know this because you kind of been on, we talk to each other almost every week. Actually, we talk to each other exactly every week and more on text even.
Yeah.
So, the process that we've gone through. We've gone through multiple publishers, myself and Dr. Dayspring, back and forth, hundreds of times, till we got it exactly right, so that an average person with a 5th to 6th grade education can pick this book up and learn everything you need to know about cholesterol all the way from the 1900s to 2025. Some of the studies that are in there are not yet published. They're supposed to be published in January 2025 and February 2025, but we have access to the proof, or the pre-publication. And so this is the latest and greatest when it comes to lipids, lipid metabolism, cholesterol, and, all things heart disease. It's actually more of a longevity book, to be honest with you. There's lots of chapters on cholesterol and how we discovered it and what it does, but a lot of it is on the types of diet you should be eating, the way different parts of foods affect your diet, the genetics of these blue zones, and, what you can do to live longer, how many years you can expect to add to your life if you did this or that thing, or you just substituted this for that in terms of your diet or exercise, or, whatever it might be. So it's more of a book on how can I enhance and prolong my life given the genetics I've been dealt. Some people were dealt amazing genetics, like yourself, and some people have horrific genetics. Some of these teenagers and 5-year-olds with cholesterols of 7, 8, 900. So it covers everything in between, but it's written in a way that an average person with a 5th to 6th grade education can open it up and read it. There is one chapter 9, that's a little bit more intricate, that is more the lipoprotein and lipid metabolism, where you probably need a high school or college degree to be able to understand that fully. But I've tried to make it as simple as possible. Dr. Dayspring tried to make it as complicated as possible, but we made it hopefully kind of in between so most people can all understand that chapter as well.
No, there seems to be a lot of disconnect nowadays, all over social media, just in the world in general. Because nowadays we have modern pharmacotherapies. We are bringing LDL levels down to such unprecedented levels that we could never achieve before. And now there seems to be a lot of concern that if you have an LDL level that is, let's say, under 20 nanograms per deciliter, that you are at risk for cancer, your hormones will tank, and you're at risk for a hemorrhagic stroke, and it will fry your brain and cause dementia. Help me debunk some of this. Please debunk some of this.
So first things first, yes, there were those concerns back when we really didn't know. And previously, we just kind of had statins, and the most potent statin is rosuvastatin. And in 2001, the Jupiter trial, finally, we were able to get people under 60. The people that ended up with LDL cholesterols in the, 57, 55 milligram per deciliter, below 60, they had no further or no future atherosclerotic events. So it was the first time ever where we could get people that low. So for the longest time, the guidelines never really recommended getting people that low. Like, what's the point of saying the speed limit on the highway in Orlando, Florida is 270 miles an hour when no car in production can go 270 miles an hour? Like, that just makes no sense. So it made no sense to say, well, we need everybody under 60 when
I like that analogy.
You can't get everybody under 60. There was no way with just statin medications, even if you added phenofibrates, which were available, and cholesterol and, bile acid sequestrants, whatever.
Yeah, okay, even that's not going to do much.
They become a little intolerable once you start stacking those on. But when you start stacking on, like, let's say gemfibrozil or phenofibrate and cholesterol, whatever was available back then, you could probably get 10% of people under 60, but not enough. So there's no point in setting the speed limit or, to that low when you couldn't get anybody that low. Finally, there was Zetia, there was these PCSK9s, there's bempedoic acid now, there's the once or twice a year injection, the inclisiran, there's all these newer therapeutics, and there's obviously apheresis. Some of these people have, I don't know if you want to get deep into that, but we can almost dialyze lipoproteins in a dialysis machine out of your bloodstream for some people that have them.
You're talking about apheresis?
Yeah, apheresis.
Okay.
People have really high lipoprotein A, or having a severe acute episode of maybe severe pancreatitis or something, which we've never used it for pancreatitis and triglycerides, but really high lipoprotein A's, those people could qualify for an apheresis. It's like a dialysis where we just clear out your lipoprotein.
Well, the new meds will come out soon for the LP(a), so we just don't have outcomes yet.
Right. Those meds are coming soon.
Very soon. 5
of them in the works. And within the next year or two, they should be available for the people who have the worst case scenarios. These are people that have had multiple heart attacks, multiple strokes, open heart surgery. They'll be approved for those people first. And then as time goes on, sort of like the PCSK9 inhibitors, as time goes on, they'll approve them for like the next group, then the next group, and then just the general public who just needs their numbers much, much lower. Or have lipoprotein A in this case that is.
What are you observing in patients of yours that you see every day that you've gotten their LDLs far below the threshold, say into the 30s, 40s, 20s, even lower than that? Are you observing any mental cognitive decline, anything?
No, so that's, I think we need to get into that. So it doesn't matter what I observe. What matters is the data, right? So I can only see in clinic 30 to maybe 50 patients a day.
Sure.
I did the math. It ends up being 5 to maybe 10,000 a year, closer to like the 8 to 9,000 mark.
It's more than me, but yeah.
That's more than you. But that's still not, a huge enough data set. So they have done huge studies. One of the chapters in the book talks about statins and dementia. One of the most recent meta-analyses looked at a population of 5.4 million people. They found that people on statin therapy had a 20% reduction in dementia.
It was a reduction.
And a 32% reduction in Alzheimer's. And this matches prior studies. Previously, people said, well, we don't know. Well, we don't know. But there was other studies before that also looked at large databases. They found that people with lower LDL and on statins because of statins. Obviously, people on statins had no increase in mild cognitive decline. This is like people say, well, I just get this brain fog. I just don't feel right. Even that was lower in the statin group. The dementia was lower. Obviously, vascular dementia is lower because it's the arteries going to your brain. The vascular dementia is like tiny little infarcts in these parts of your brain. We call them lacunar infarcts. It's like mini strokes that happen in these tiny little areas because you have plugged up arteries in little small parts of your brain. You start slowly getting confused over time and memory issues, and your hand starts maybe to tremble a little, or you can't find the words. It happens over decades. It's microvascular dementia. And people with really high cholesterol, sort of like how you have, heart attacks, mini heart attacks, whatever, but these are like tiny and usually imperceptible, but over a long enough time horizon, it becomes obvious. But they looked at even mild cognitive decline. People on statin medications had less mild cognitive decline, less dementia, less Alzheimer's dementia, and less microvascular dementia. That one is obvious because we're getting rid of the cause of vascular dementia. So they have found that over time, but recently this large, gigantic study in 2023, it is in the book in a huge section demonstrating a 20% reduction in dementia and a 32% reduction in Alzheimer's in people on statin therapy. So that's the one thing that people always say, well, yeah, you might lower your cholesterol, but you lose your brain or you get dementia or, good luck living in
I've heard a lot of primary care guys talk about saying that statins and dementia, and it seems like they have it backward.
Yeah, they definitely have it backwards, which is why this is another reason why.
Like ass backward. They got it backward. Okay.
They definitely got it backward. But that's another reason why I wrote the book, is because I want doctors, this is going to be the future book, hopefully, that all doctors have to read to understand cholesterol. There is no correlation with taking statins and dementia. In fact, it's the opposite.
Hear that? No correlation. You heard it from the man himself.
Not only no correlation, but it's a net benefit. People on statins have less dementia. Like, that's not even a question. So that's one thing. The other question that people bring up a lot as well, if you get your cholesterol super low, then you may end up with low testosterone or low androgens, low cortisol, low estrogen, low hormones, because cholesterol is the building block of all hormones, which it is. Absolutely, without question, the first step towards making any of your hormones, whether it's cortisol or androgen or adrenaline or any of them, whether the signaling ones or the non-signaling ones, the gonadotropic or steroidogenic ones, like estrogen, progesterone for females, testosterone for males. People say, well, what if you get your numbers so low? Doesn't that lower your testosterone? There is no good data or evidence that shows that. And not only that, first of all, if you understand the physiologic ways in that the body makes cholesterol, every cell in your body makes cholesterol, including your testicles, your ovaries, your adrenal glands, every cell, any cell that makes every cell in your body makes cholesterol. All you need is a citrate and an acetate molecule. Those are the first two building blocks of cholesterol, a citrate and acetate, which is available in every single cell in your body. You don't need to consume cholesterol. You don't need to eat anything. You just existing have citrate and acetate in your body. And you can go down, it's like a 32, 37 step process, and you will make cholesterol. And then that cholesterol can be used to make any number of other things, vitamin D, testosterone, estrogen, whatever you can think of can be made out of it.
Is this separate from circulating cholesterol?
This is cholesterol in your cells. So,
okay.
So your cells make it. Even your brain makes it. Another thing people say, well, don't you need cholesterol? Your brain is made.
That was my next question. Do our organs need circulating cholesterol?
That one. Maybe we'll get to the brain in a second. So just remind me, because I'm going to lose my train of thought.
Okay.
So your cells, every cell in your body, including your eyeballs, your skin, hair, maybe not hair, but everything in your body, every cell makes its own cholesterol. You don't need excess cholesterol. The excess cholesterol gets trafficked in these lipoproteins back to your liver. The yellow inside is cholesterol. It gets trafficked back to your liver to be eliminated. Then it gets dumped into your intestines. And unfortunately, what happens in your intestines is most of that gets reabsorbed. So we have medications that block absorption, and we have medications that block synthesis. So what happens is, let's say we get your numbers super low. We get your LDL cholesterol down to 10 or 20 or 5 even. All the studies that they've done on people with super low LDL, it has zero effect on their testosterone, whether we drove it down with medications and therapeutics, or they were genetically born, with super low LDL cholesterol. Now, the reason for that is if your body, so first of all, your body doesn't need to have high cholesterol to make testosterone. Like I said, your testicles can just make it. But let's say you were in a state of an acute illness. You were super sick. You're in the ICU. You need more cortisol. You need more testosterone, whatever it might be. You're like in an acute illness and you're very, very sick. There's a receptor on your testicles called SRB1. That's also a chapter in the book. But the SRB1 receptor actually gets your HDL, not LDL. It'll actually take your HDL and acquire the cholesterol that is in that to then make extra cortisol or testosterone, whatever it might be. There's way more HDLs in circulation. There's 27 times more HDLs in circulation than LDLs. So when we take out like a deciliter of blood, there's 27 times more HDLs than LDLs, and driving down LDL has obviously no effect on HDL. So if you were in an acute illness and you were septic, or you were sick, you're in the hospital, you need, let's say, more vitamin D or cortisol or estrogen, whatever it might be, your cells that need that extra cholesterol have a receptor on it called SRB1 that can grab the HDLs, and then you delipidate it or take out some of the cholesterol that's in it, use it for whatever reason, and then it goes on its way. Now, this is incredibly rare and almost never happens. So people who are worried or concerned about this, don't worry. There is a backup system that does that. Now, in addition to that, even in the studies where we've driven people's cholesterols down to almost nearly zero, like, the Fourier trial where people were already on statins, already on Zetia, already on, bempedoic acid, already on whatever. They were on everything. Their LDLs were like in the 60 to 70 range to begin with. You added Repatha to it. That's the Fourier trial. You added Repatha to it. 10% of people in that study ended up with LDLs below 15.
Absolutely. Yeah.
20. And some ended up with LDLs, I think a small percentage, I think under 6 or 7%, I forget the exact number, ended up with an LDL cholesterol of 0.2 millimoles, which translates into 7 milligrams per deciliter. So some people ended up in the single digits of LDL cholesterol. There was no incidence of hemorrhagic strokes. There was no increased incidence of lower testosterone levels, losing libido, any side effects, lack of energy levels, any of that stuff. But what we did find, and this is even true in the open label extension, they call it the Fourier-Olay open label extension. This is the one where they continued following them even though they had super low levels. They found, and that's still ongoing, obviously, they found that those people with the lowest LDLs had even less vascular events, less heart attacks, less strokes, no increases in any adverse side effects at all whatsoever. So there's this myth where, having super low LDLs causes hemorrhagic strokes or causes this or might reduce your libido or might reduce that. Turns out none of that is actually true. And there have been studies that looked at those exact things where, correlating super low LDL levels, whether driven down or naturally born that way, versus testosterone levels. And there's been almost no correlation. Now, your audience would like to know this. If you have really low testosterone, your lipids may be slightly higher, which is not good, generally speaking. When you have higher LDL or higher total cholesterol and your testosterone is low, they have found that putting people on testosterone replacement therapy actually improves your lipid markers.
Because the testosterone helps oxidize fat mobility a little bit more efficiently. Would that be the reason?
Well, we're not really sure the reason. I mean, it's also something like with your thyroid too. If your thyroid is way off, you're hypothyroid, and we replace that, your lipid numbers get lower. Your total cholesterol goes down, your LDL goes down. So we generally don't treat people with thyroid issues. We don't treat their LDLs or their cholesterols until we get them euthyroid or, back to normal thyroid. Same thing goes for people with low testosterone.
Interesting.
Once they're on testosterone replacement therapy, then we check their lipids and make sure, yes, this is a problem, or no, this is not a problem. But generally speaking, the effect is not huge. So if somebody's testosterone, let's say, is like 50, which is obviously incredibly low, and then you put them on testosterone replacement therapy, and now it's like 500 or 600, which is considered, pretty average, pretty normal. Nothing you would be like, oh my God, that's really low. You're not going to have like a massive decrease in their LDL cholesterol.
So it's clinically insignificant, you'd say?
I wouldn't say it's completely clinically insignificant, but it's not to the point where you're not going to end up on medications, right?
Okay, I got you.
Say your LDL is like 135 and you're like, yeah, but my testosterone's 100. So we treat your testosterone, now it's 400 or 500, 600, whatever, pick a number. It's not like your LDL is going to be like 60 now. You know what I mean? It might drop to 110, 115, 120, but it's not going to go from 135 to 35, right? So that's just not possible. So for people looking to optimize their health and longevity, just being put on testosterone is generally not going to lower your cholesterol enough. So we do want to make sure your cholesterol levels are within normal range or the range that you prefer or feel the best at, given. But it's not going to be enough, generally speaking, to lower your lipids that significantly. It might be a 10 to 15% change, but like you said, maybe not enough. So clinically significant, but not enough if you're trying to optimize for long-term better health. So
the benefits of these very, very low LDL levels. Is this independent of triglyceride and HDL levels?
Oh, yeah, absolutely. Okay. So they've done those studies where they've looked at HDL levels and triglycerides. Now, I've done long videos on triglycerides because I think there needs to be a lot of nuance in how we explain it. If we artificially lower your triglycerides with, say, medications, right? Fenofibrate, fish oil maybe. There's a few medications that almost just target triglycerides. You're not going to see like a huge, improvement in outcomes. There might be a little, but it's generally not like a significant, it's not going to move the needle a huge amount. However, if we lower your triglycerides with lifestyle changes, for example, you lose weight, you stop drinking alcohol. Alcohol is a huge one for triglycerides. If you are diabetic and we finally get your diabetes under control, which is the most common, the most common reason nowadays that people have high triglycerides is generally they are diabetic and don't know yet. They're like pre-diabetic and haven't, been told or aren't under control, or they're diabetic and have not been controlled at all, or they need tighter blood sugar control. So those are kind of the main ones. Chronic kidney disease is another one that raises triglycerides. So we have found though, like if somebody makes the necessary changes to lower triglycerides naturally, like start weightlifting, cut your calories, lose weight, stop drinking alcohol, get on metformin if your diabetes is out of control, whatever, diabetes medication there may be. And sometimes weight loss alone will improve diabetes. If you make all those changes, your triglycerides will go down. That will improve outcomes, but not because of the triglycerides. It's more so because you did all the other things. You're doing cardio, you're cutting out alcohol, you're exercising, you've lost a ton of weight, whatever it might be. So it's independent of that. There have been studies that have looked at us artificially lowering triglycerides with statin medications, right? Because statins do lower triglycerides. Look at, let's say we put somebody on rosuvastatin 10 or, whatever it might be, and their triglycerides go from 180 down to 80, but their LDL drops from 135 to, let's say, just 35, right? I'm just making up numbers here. The risk reduction is absolutely there, but it's concomitant or commensurate with the drop in LDL. Has nothing to do with the triglycerides.
I think that was shown proven in the Prominence study with fenofibrates.
So fibrates too, yes, and there was a study, I forget the exact name of it, where they use a whopping dose of a fibrate. They use fenofibrate,
and it did not decrease the events or death. That was the Prominence study, I believe.
Right, but that may be the Prominence study, but the other trials where they put people on a medicine like fibrates or others that reduce the triglycerides, the only time it would show outcomes benefits is if it also reduced the LDL, and they found that across the board it matched the other trials. So for example, we know for every 1 millimole reduction in LDL, which in American is like 38.6, for every 38.6 milligram per deciliter reduction in LDL cholesterol, you get about a 23 to 26% reduction in all cardiovascular outcomes, right?
Wow.
So let's say you put somebody on a medication supposed to lower triglycerides, and their LDL is also like 135. If it drops by, or let's say 138.6, their LDL drops by 38.6, which is 1 millimole, and their triglycerides drop a little bit too, and now you get a 23% reduction in all cardiovascular outcomes. It's not because you lowered triglycerides, it's because you lowered the LDL by the expected 38.6. So unless that happens, you don't see an independent signal by just lowering triglycerides unless it also comes with lowering LDL. Now, the HDL is a little bit different.
Which is another myth, because there's a lot of people that think that, oh, well, my LDL is high, but my HDL is high, so that counteracts it. Why is that a myth?
You're absolutely correct. We used to think, based on the Framingham data, and this is like back in the 1980s and
Sure.
90s, we used to think that people with high HDL were somehow protected from heart disease. Well, they never corrected for ApoB or LDL. They just noticed that people with higher HDL sort of didn't have as many events, but it also turned out they had lower LDL, and they never, thought of it that way. So they've gone back and analyzed all the data on HDL. The last time we really cared about HDL, I would say, is probably like 2011, 2008, maybe.
Yeah.
We now know that HDL is not protective.
That was like niacin. That was like, right. There was other studies where they raised it didn't do anything.
Exactly. The NISPAN study, the AIM too high,
that was it. Yeah. AIM too high. Yeah.
It was called AIM high, but we called it AIM too high.
Right.
Because it ended up having no benefit, and it actually caused harm. So the niacin trials, which like pushed people's HDLs through the roof, like, people would go from like a 30 or 40 to like 140, which we've never seen before. Ended up having worse outcomes.
Wow.
Not only no benefit, but
wasn't it liver toxicity?
Liver toxicity. Okay. The metabolites of niacin itself were pro-inflammatory. That's a whole chapter.
Ball game. That's it. Yeah.
The metabolites are pro-inflammatory. Not only that, here's the kicker. It actually makes your HDL particles, these phospholipids on the outside of your HDL particles, it made them atherogenic.
Yeah. So that's interesting you say that, because I had a lipidologist that once told me that, and I had never heard of HDL being atherogenic, so she caught me by surprise with it.
Not atherogenic at all. Like you said, we used to think it was protective.
Yeah.
But it turns out niacin actually made it harm. So, all the good cholesterol now became horrible cholesterol. But not only that, it increases insulin resistance. It causes that darkening of the skin, that acanthosis nigricans, which means you have really bad insulin resistance, or like end stage insulin resistance. So it has a lot of bad effects. There was these other class of medications called CETP inhibitors.
Biscatrib? Yeah.
Yeah. There was a few that have come out, back in the 2000s. There was 3 or 4 of them they tested. They ended up causing more harm than good, but they raised people's HDLs to astronomical levels.
Yeah, it was very high. Well, it did a lot of good. It raised HDL too high. LDL dropped by, I think, 30%. The LP(a) dropped too, but the problem was there was some risk.
Liver failure, and people died.
Yeah.
So they got rid of that. They have a new CETP inhibitor, a couple that are like.
You're talking about the Brooklyn study, which just got finished.
Yep, and they don't seem to be causing harm, and they do seem to be helping lower LDL and reduce outcomes. We'll see. Like,
those are a ways out. You're looking at probably 2028.
All of these things are like, yeah, we'll see. The mechanism of action makes no sense. The CETP inhibitor, I'm sure you know it, but maybe your audience doesn't. In circulation, an HDL molecule. So this is why like calling these bad and calling these good makes no sense, right? This is an HDL, all right? It has these blue things on it that are A1s. They're called apolipoprotein A1. It can have up to 5 of them. And I only have 2 on here, but it can have 1 to 5 of them on here. Whereas a low density lipoprotein molecule only has 1 ApoB. But these take cholesterol out of your arteries, and in circulation give it to LDL, and this takes it to your liver to be cleared. So a huge portion of an LDL particle's lifespan is helping you clear cholesterol out of your arteries. Now, the molecule that connects these two together is called the cholesterol ester transfer protein, the CETP, which the only reason that LDL lipoproteins have cholesterol in them is to hold them. It's a structural protein to hold them open so they can give their triglycerides, the turquoise parts, to an HDL for its cholesterol. It's called a cholesterol ester transfer protein. Oops, what happened to my screen here? Can you see me still?
I can see you fine.
Oh, some big window opened up on my screen. There we go. So the cholesterol ester transfer protein makes the HDL that had collected cholesterol out of your arteries, give it to the LDL in exchange for triglycerides to then take this and go dump it into your liver, which then dumps it into your intestines so you can poop it out. So the only function of cholesterol inside an LDL is actually to hold it open, to, keep it inflated. Otherwise, it would be like a deflated, like a paper bag that's deflated and empty. It would kind of be like collapsed on itself. So the cholesterol in an LDL, the main purpose that it serves is actually to make it a fuller volume so it can collect more cholesterol and collect more cholesterol from the HDL. So that's the main purpose of it. A lot of people don't know that.
Yeah. Debunk this next myth, because we always talk about what comes first, the chicken or the egg, be it the inflammation or the LDL. And there's a lot of talk saying, well, my LDL's high, it's okay because my high sensitivity C-reactive protein is really low. Okay. Where do we go with that?
So this is another really good myth that a lot of these influencers online say. Well, they say it's not the cholesterol, it is the inflammation that is the first step towards causing atherosclerosis. Well, it turns out that has been tested. Or they say cholesterol is just the good guy coming in to fix the damage. Well, it looks like that's been tested too. So back in the early 70s, like 73, 74, that's what we thought. And there are these online medfluencers, healthfluencers. I just call them idiots. There's online idiots that want you to believe that, cholesterol is this nice little friendly thing that comes in to patch up the damage that has been done by other things, smoking, hypertension, sheer stress, whatever. Well, that was called the response to injury theory. And like I said, all this is in the book. If you want to go in there, read that chapter and click on the actual studies themselves. Every single one of these things is a study, if not 10. So they thought that was the case, and they actually tested it. Tabas and Williams were like, hey, let's go in and damage arteries. So they went in with catheters, scratched up arteries, and said, let's check back in a few hours, and then a few days, and then a few weeks, whatever. Yeah, it's wild. The part that they scratched up did not form atherosclerosis, but the part right next to it did. So you need healthy, intact endothelium to actually form atherosclerosis. The part that they denuded, where they scratched up, that's the medical word for it. They denuded it, they scratched it up and damaged it physically, did not form atherosclerosis. It kind of like scabbed over and healed. So you need intact, super healthy endothelium to form atherosclerosis. All that's required is high, low density lipoproteins. When they're too high in concentration, they go into your arteries. Now, once they go into your arterial wall, once they get into the intima, that's where they connect with reactive oxygen species and start the whole damage inflammatory process inside the arterial wall. This is not something.
So that's where the macrofoam cell fatty. Okay, so that's where it all. Okay, I got it.
Exactly, and that is not something we can measure. That is not something that there's a blood test for. The only way to measure it is on autopsy.
Yeah, right.
And we have. And that is how we found out that this happens, is because Vietnam War veterans and children that died in car accidents, when you do autopsies on them, the higher their cholesterol, the more fatty streaks they had, the more plaque they had in their arteries and whatnot. Even it starts in your teenage years. They also found that mothers who had really high cholesterols, they had miscarriages. Their fetuses, if they had cholesterols of 300 or more, their fetuses had fatty streaks in their aortas. So this is not like some weird theory that we're just making up. I mean, this is actually, the scientific method tests these things. So we have tested this, and it turns out to be true. Now, the other question is about inflammation. Well, what about if you just have high CRP? They have done those studies as well. Inflammation is not required. There's actually a chapter in the book called You Don't Need Inflammation. No. Inflammation is not required to have atherosclerosis. All that's required is one single thing, and that is really high LDL cholesterol. If your LDL cholesterol is high, it's going to cause atherosclerosis whether you have inflammation or not. In fact, the Jupiter trial was that exact study. They compared people with high CRP to low CRP, and they crushed their LDLs down into like I said, some of them below 60. But these were all people who had generally an LDL that was like in the 100 to 70 range, and they crushed it even lower. And they found that, yes, the people with the lowest inflammation and the lowest LDLs did the best, but that for whatever reason, the rosuvastatin seemed to lower the CRP in and of itself. So it seemed, at least for a period of time, that lowering LDL lowered inflammation for whatever reason, But CRP is not something like we go and randomly check on people. The other big myth that
it's part of a lipid. It's part of a comprehensive lipid panel.
CRP?
Yeah.
No, it really shouldn't be. I mean, there's almost
it shows your total cholesterol, your HDL, your LDL, your VLDL, your triglycerides, and a lot of times it'll show your HSCRP.
I mean, you have to order it separately. You could, but it's generally not part of your normal.
So we can conclude that the number one cause of death, which is atherosclerotic cardiovascular disease, ASCVD, heart disease, heart attacks, and strokes. Can we conclude that the lower we tank those atherosclerotic LDL particles, we can prevent heart disease completely?
Oh, we could absolutely completely eliminate heart disease. In fact, like that's the subtitle of the book. You can read it right there.
There you go.
Right, it says that we can completely eliminate heart disease. I mean,
so this is one of the real keys to longevity.
It's probably the number one thing you can do that is modifiable, right? If you look at the top 10 causes of death in the United States, number one is atherosclerosis, heart disease, right? Number two is cancer. If you eliminate alcohol, obesity, and smoking, that's like 70 to 90% of cancers, improve.
And that's what we really focus on testosterone. We have what's Dr. O'Connor's dubbed the ABCDs, all right? A1C, B, blood pressure, C is cholesterol, and we're big on that. And this is what this falls on is C, is cholesterol. And so go ahead. Don't keep going.
You off, but I want to finish the thing on inflammation because I don't think.
Oh, say it.
They might not be fully convinced. There are children that are born with insanely high cholesterols. These are the familial hypercholesterolemias, the homozygous. These people have their first heart attack at age 5 and continue to have them and are dead by 13, maybe 20 if they get lucky. Now that we have modern therapeutics, if they're caught young enough, they might live past 20. These kids have no inflammation. I mean, these are like 5-year-olds that are, brand new kids that have, zero inflammation. They've checked every inflammatory marker you can imagine, not just CRP, IL-6, IL-1, homocysteine, uric acid, TNF. I mean, there's a million inflammatory markers you can check, and these kids have none of them. So that just adds more data. The other thing I was going to say is that, people say, well, I'm young and healthy and I did a calcium score. I'm fine. Do I really need to take something? Well, that study was actually done too. There was a study called the Prevention of Early Subclinical Atherosclerosis. This is called the PESA trial. They looked at that exact group of people, 40-year-old humans, men and women. 40-year-olds, was the median age. So half were below 40 and half were above 40. These were people with like mostly zero calcium scores. BMI was not overweight, non-smokers, young, healthy. They ate well. They did everything right. If their LDL was 110, 45% of them had subclinical atherosclerosis. If their LDL was 130, it was 55%.
Despite the calcium scores being zero.
All their calcium scores were zero.
Key finding right there.
Yeah, no.
So this goes to all the people who have calcium scores of zero that believe they don't need to be on a statin because their calcium scores are zero despite their LDL being high. Thank you.
Yeah, and I'll show you like a graphic or a visual that'll even solidify that more. People with an LDL in that same cohort that had an LDL of 150, 68% of them had atherosclerosis. Not only that, if you took all those people, in the 110, 130, and 150 group, you took all comers in that group, of the ones that had atherosclerosis, 63% of them had it in more than one arterial bed. So they had it in their carotids, their femorals, their aortas. They had it in more than one arterial bed. Now, they used super fancy imaging. They used like 3D IVUS, MRI and SPECT, and all these like fancy imaging to detect subclinical atherosclerosis. This is not like, we did a CT angiogram and we found blockages.
Yeah.
This is like way before, like decades earlier.
Wow.
Blockages. And I'll show you.
No, that is, keep going. So, show this, yeah.
I just want to show you this visual because I think it's important. This is what a normal endothelium looks like. This is early. This is where the PISA trial was detecting. We have no way of detecting this in normal studies. If we inject dye and do a CT angiogram or a cardiac catheterization, you're injecting dye in here and it looks wide open. You have no way of seeing inside the walls.
Wow.
It starts to happen over here, right? Late stage is where calcium starts to happen. So what I usually tell people is, do you really want to wait until we see calcium on the CT scan to finally lower your LDL cholesterol.
I like your analogy where you said that's like, you might as well keep smoking. It's like smoking and just wait to stop smoking until you get cancer.
Well, no. So some people like just think of this logically. Would you ever tell your friend, "Oh, it's okay to keep smoking. The CT scan they did last week on you didn't show lung cancer," and then 5 years later, "Oh yeah, you can keep smoking. The scan was clear." And then like when they're 50, it's like, "Oh, dude, you got some nodules. Oh, dude, you got cancer. Now you can quit smoking." Like that's just insane. You would never tell someone to keep smoking until we found lung cancer on their CT scan. That's kind of the same thing with a CT angiogram or these calcium scores. People think, well, I just did a calcium score. I'm clean. You're not clean. Do you really want to be that person that waits till here and now you get the calcium? And look, the lumen is still open. Like the inside of the artery is still pretty open up until late stage where there's no more room for it to go. It remodels outwards. See how the artery over here is kind of skinny and it remodels outwards? The artery remodels outwards in the beginning phases to keep itself open because it's trying to preserve you. It has like the self-preserving property where it's trying to keep you alive. Eventually, it starts to get narrower and narrower, and that's kind of when you start to see the calcium. And then there's like really no going back. Once you have atherosclerosis, there's no way to make it go away. But if we catch it early, let's say you're still here, we can stop it from progressing. You don't want to keep your LDL high and keep going to here where it's like too late and it's kind of narrow. And now when you jog a mile somewhere at the halfway point, you start to feel chest pain or shortness of breath. We want that to stop, decades before so that you can keep exercising. Even though you have some plaque, it's just not going to get worse. If we drop your LDL below 60, below 55, we know that for most people, they'll no longer be building plaque. 60 is kind of that cutoff. The PISA trial showed the same thing. The PISA trial showed above 60, you had atherosclerosis. Below 60, you didn't. The European guidelines that were published a couple years ago, their cutoff was about 40. Above 40 milligrams per deciliter, you had plaque, and below, you didn't. So it just depends on how strict you want to be. But the number one way you can improve your lifespan that is modifiable, there's a few things that are modifiable that we can change. And, when you look at actual longevity, data and things that actually kill us, then the number one most modifiable thing is lipids. Number two would be like lifestyle stuff, like eating a healthier diet, quitting smoking, exercise, more fruit, more vegetables, socioeconomic status. Obviously, if you have more access to resources,
and nowadays we have the pharmacological interventions that could get people to LDL levels to where atherosclerosis should not even be a concern.
One of the biggest publications that I actually published word for word in the book was by these three cardiologists, Peter Toth, Michael Shapiro, and I believe Maciej Banich out of Poland. They said that we're not doing a good enough job, that we now could completely eliminate heart disease. They're saying that with today's current guidelines, we've eliminated about 70% of heart disease.
Well, we could if everybody would cooperate. The problem is people go against the people like, oh no, it's not the LDL, and they listen to the carnivore diets, spiking people's LDLs through the roof. I mean, it's bad out there.
If you have the book, I know you do, flip to that one chapter. But it says we've reduced the burden of atherosclerosis or heart disease 70%, but that's not good enough. What about the other 30%? Why are we allowing 30% of people to still run around with heart disease when we can completely eliminate it? And I actually published their public that part like word for word because it was so good. I didn't want to summarize it. I didn't want to do it. So I just took their example.
Well, I think a lot of it has to do with the patient trusting in what the cardiologists are saying.
And part of it is the doctor even knowing this. How many doctors you say you talk to every day?
A lot, like 10, 12.
Would even tell you we could eliminate heart disease completely?
Right, but I think another big problem, an obstacle is that the internet has really has really prevented that because the internet has given people a voice that are talking about this disease state who have no idea what they're talking about.
Absolutely. And I think the internet is the democratization of knowledge. Anybody can flip their camera open and start talking. Yeah. It's hard for the public to figure out, okay, who's reliable and who isn't, right? I mean, I get these people tag me in videos all the time. They're like, hey, is this true? Most of the time, if you're tagging me in a video and saying, is this true? Most of the time it's not. But there'll be this guy on there wearing the blue blocker glasses and saying something.
Oh, yeah.
Cholesterol is our friend. Why do you want to lower it? It makes testosterone. Like, okay, logically, that kind of sounds reasonable. But then it's like they don't understand the pathophysiology, the lipid metabolism, like most of the topics we covered here so far. They don't understand all of that. And even to them, it makes sense. And if you're a doctor, like I've had many doctor friends of mine reach out to me, even a freaking urologist, urologist who should know about this stuff. Like, you're a urologist. Your job is to understand testicles and testosterone and hormones. Reach out to me and be like, hey, any truth to this? And they'll tag me in one of these videos about.
Well, there's also a lot of, the misinformation. Like, for example, I'm having a conversation with a guy the other night, and he was telling me that, I tell him what I do, and he's like, oh, my doctor wanted to put me on statins, but I said, no, I'm going to do something natural like red yeast rice. And you hear the silliness in what I just said and I had to explain to him, like, you understand, statins are derivatives of red yeast rice. So I thought it was really interesting because there's people that believe I want something natural. And let's go down the list. Many pharmacological interventions come from natural origins. Statins, red yeast rice, aspirin, which is oil of wintergreen.
In the world of cardiology, especially, the number one most prescribed medication that reduces stroke rates and heart attack rates by 82%, which is aspirin, is oil of wintergreen.
Metformin, French lilac plant. We could go down the list.
The new weight loss meds, Ozempic and all that.
Comes from a lizard.
The saliva of a lizard.
ACE inhibitors come from snake venom.
Viper venom.
Viper venom, that's it.
Coumadin, which is a blood thinner, is
sweet clover.
Yeah. The digoxin plant. You're familiar with these because you work in cardiology. The digoxin plant, the leaves of it were it's called the foxglove plant, the medicine for digoxin. But, all of these medications come from something in nature. The problem is people have this natural fallacy where they think that if you get it from nature, that means it's better. Well, it's not, because you can't dose it. Like, if you were to actually take red yeast rice and consume it, the molecule in there that is the statin is called monocolin K.
Monoglobin K, yeah.
Right. But the rest of the stuff in there can kill your kidneys. So we can't dose that. We don't know what formulation it is. We don't, they're made in China and India usually, and you have no control over what's in it. It's not FDA regulated or approved. I don't know if you're taking 5 milligrams or 500. Who the hell knows? But when we put it in an FDA regulated, dose, and it's like 5 milligrams of rosuvastatin, we know exactly what's in it. The SPORT trial by Cleveland Clinic was recently done. SPORT, S-P-O-R-T, looked at 6 different supplements versus placebo versus rosuvastatin 5.
Oh, I saw that.
Fish oil, garlic, CoQ10, red yeast rice, cinnamon, turmeric, some other things.
Some of them actually, the herbs actually raised the inflammatory markers.
They raised inflammation.
Yeah. I think it was cinnamon, yeah.
Right. Cinnamon raised inflammatory markers, but the rest of them did not beat placebo.
No.
And rosuvastatin crushed. No one went up. All of the other ones, some went up, some went down. Like all the other ones that were placebo controlled, even in the placebo group, some went up a little, not as much. But in the other ones, some went up, some went down, 3 to 5%. Rosuvastatin, everybody crushed. Nobody went up. They all dropped by 5% all the way up to 55%, which we know about rosuvastatin. Some people, most people, it goes down 35%. Some people it goes down 55%. So they crushed it. And not only that, but they found that the more people stopped the supplements due to side effects, and no one stopped the statin. There was no side effects from the statin because it is like the cleanest, most pure, cleanest of all the statins. It's the most synthetic, has almost no side effects. But all of the other things, the garlic and the whatnot, they all stopped it due to GI side effects, diarrhea, bloating, couldn't tolerate it, headaches, weird, rashes, whatever. They stopped all of the more people in the.
Well, assuming you're healthy, man. If you had somebody with like CKD advanced, you would give them a low dose of Rasuva, right?
No, it doesn't matter at all. There's no reason to adjust the dose of the statin for kidney problems.
Okay.
Rosuvastatin is one of the preferred ones. Pravastatin and rosuvastatin are preferred in kidney problems.
Okay.
Because they have the least liver metabolism.
No, I think it's interesting because, like, I would be willing to bet that probably, this is a bold statement, that probably a good majority of the patients in your practice who've already graduated, unfortunately, to a cardiologist that have to talk to one involuntarily, as opposed to I'm talking to you voluntarily, they'd be dead if it wasn't for pharmacological medications.
You could, in my estimation, and when you talk to these longevity experts, like Charles Brenner and some of these people, you should actually get Charles Brenner on your show. He's fantastic.
Right.
But when you talk to longevity experts, they estimate that modern therapeutics, modern medicine, modern whatever you want to call it, has added 30 to 50 years to our lifespans. And
I want to hear that again. Modern medicine has added 30 to 50 years to our lives. That is a power statement right there. I like that.
And now
bold statement. I like it. So yeah.
And so it gets even better. Most people in the United States are overweight, right? 80% are overweight, 40% are obese. Now the death rates from heart disease have been declining since the 1960s, almost every year. Mm-hmm. We've had almost a 70 to 90%, depending on which study you look at, 70 to 90% decline in death rates from cardiovascular disease since the 1960s. Now, this is despite higher and higher obesity rates.
Yeah.
Now that we have GLP-1 medications,
100%.
and the obesity is starting to trickle down, and finally we made a dent in it and it's starting to go down. Now imagine, fast forward 5 to 10 years, we've cured obesity and people are back down to BMIs that are reasonable, under 30, under 27, whatever you want it to be. Imagine how much survival rates would be with, in terms of heart disease, metabolic disease, chronic kidney disease, heart failure, all the stuff that we deal with every day that you deal with too. Imagine how much improvement those would all have with less obesity. Because we know that, losing weight and getting to an ideal body weight helps with sleep apnea, atrial fibrillation, arrhythmias, chronic kidney disease, heart failure with preserved ejection fraction, with reduced ejection fraction, with lipids, with diabetes, with hypertension,
we're seeing improvements in heart failure just using the GLP-1s now.
Yeah, absolutely. And there was a video I posted on YouTube. Is it due to the weight loss? Or
That's what I was thinking too. I was about to ask you, do you think it's just because of the weight loss, or there's a mechanism behind the GLP-1s?
So they did look at that, and all people on GLP-1s, so they reanalyzed the data in that heart failure study to see if it was due to the weight loss or not. So they broke the participants down into those whose weight changed by more than 5% to those whose weight did not change by 5%, whether up or down. So people had almost like no weight loss, or no weight change, versus those who had more significant weight change. Both groups did improve heart failure symptoms, whether they lost weight or not. But obviously the group that lost weight more than the 5%, or, up to any level, the more weight loss they lost, the more improvement they had. So, while it is true that, whether they lost weight or not, or whether they had diabetes or not, they still improved their heart failure symptoms. But they did find that obviously the groups that lost the more weight obviously had the more benefit.
Yeah.
So there definitely does seem to correlate, and go with weight loss. But even the groups that didn't lose any weight still had improved symptoms and outcomes, which is fantastic.
That really is.
Right. And that's something people didn't expect. Like they said, it's got to be due to the weight loss. Well, they went back and said, well, let's take a look. Let's look at people who did lose weight versus those who didn't and see if it made a difference. So if you fast forward 5 to 10 years, now that chronic obesity seems to have been solved, once these medications get a little cheaper, now that there's going to be pill versions of it, Ozempic and these GLP-1s, there's like a whopping pill dose, a PO dose, pill that can be taken, which will be obviously cheaper and more available to the masses. Now that those have been shown to cause weight loss, once people actually lose weight and we're still reducing heart disease and death from heart disease, imagine the amount of longevity benefit that we're going to have with metabolic and chronic disease burden also drops. And the amount of cancers that will be resolved or cured, or the incidence will go down, because obesity contributes significantly to cancer as well. Like I said, alcohol, smoking, and obesity are like the top 3 contributors to most cancers. So now you could take away all 3 of those. People could lose weight. They can stop drinking. They don't have to smoke. Heart disease goes down. Some of the cancer burden goes down as well. Those are the top 2 killers. Imagine how much more lifespan we could add to people if we manage to pull that off. the burden of chronic disease goes down, as well as, all these.
Well, I think you say if we pull that off, and what I think is a real blessing to be alive in this era is that for the first time, we live in an era where we have the pharmacotherapies that could fix these problems that you have just addressed. If this was 10 years ago, we probably couldn't. Okay, but we are now in that golden era, per se, of advanced medicine where this can be done.
Yeah, absolutely. And it's fantastic.
You just have to trust the science.
Andrew, I'm sure you've heard of this because you're in the pharmaceutical industry. There's CRISPR technology. I'm not sure if you.
Oh, yeah.
There's CRISPR technology. One of the new PCSK9 medications called inclisiran is actually a CRISPR product. It's one of the first medications that came out of this CRISPR technology. We found that people that have a PCSK9 loss of function gene mutation, it's one single SNP or single.
Isn't that me?
Probably. You have LDL cholesterols that are incredibly low genetically. You may have a PCSK9 loss of function gene. So we found the little gene mutations, a single nucleotide polymorphism, where if it's one single nucleotide, we can go in and do like gene editing almost with this CRISPR technology. That's what inclisiran is. Inclisiran is a twice-a-year injection, goes to your liver, snips that piece of mRNA. It's called silencing mRNA or mRNA silencing. It goes in there, snips that with this fantastic new CRISPR technology, and all of a sudden, you have a PCSK9 loss of function mutation and your LDL tanks. And
you see, when doctors would see that, and I would show my blood, hey, like my LDL is like really, really, really low. Some primary care guys would be like, oh man, that's really bad. That's not good. And then finally I meet this guy named Dr. Allo to my right, who's like, actually, man, it's the exact opposite. That's like really, really, really good. And I'm like, you know what? I like this guy. I'm going to go listen to him. All right.
Yeah. If you do everything else right, which, just knowing you, I know you do, you could probably live to 100 and be like full faculties. Your brain is fully intact. You're muscular. You can lift weights, deadlift, run around, do all that stuff and have no issues. And I think that's what we're trying to optimize. We don't want people just to live longer. Lifespan is important, but health span, right? We want you to be able to do the things you want to do at age 90. Like you want to go to your great kid softball game, whatever it might be at that age. If you're who knows? But we want people to be able to be super functional. And the inclisiran is twice a year. They are working on formulations that it could be like an 18-month, silencing mRNA and a once in a lifetime. Imagine if you're born, Andrew, and they're like, hey, they offer you this at birth, kind of like they offer you some of these weird tests. They're like, hey, by the way, we can give your kid this one shot and their LDL will be like 15 for the rest of their life. Like,
I don't think the world is ready for another vaccine, but I like where you're going with it.
A vaccine? It is kind of like a vaccine for heart.
It is.
So yeah, I don't know that I would call it a vaccine. It is.
Yeah, I'd call it something else just for marketing purposes.
Yeah, I guess.
Yeah.
But definitely where the world is headed and the amount of like fascinating things that are going on, the space of longevity and health span and all of that lifespan is just amazing. And I think people need to stop fearing this stuff. Like I get on these people get on my videos and they're like, well, we should eat like cavemen used to eat 5,000 years ago. I'm like, dude, they lived to like 30.
Yeah. Right.
Why do you want to do that when, okay, then why are you living in an air conditioned house, driving a Tesla?
That's a good point. Yeah.
If you want to live a hard life, dig a hole in a cave and wear nothing and run around all day trying to catch lions to eat them.
It's like we might as well go back to fighting wars with bayonets and horse and buggies, like
drones, right? Or, hacking software, whatever.
Yeah.
But yeah, like some of these people, it just makes no sense. On one end of the stick, they're like, well, I drive my Tesla to work. It's fantastic. But then they're home. They're like, I just want to eat like a caveman.
And for the majority of people, these medications, I mean, unless you need advanced intervention like PCSK9s, GLP-1s, these drugs are generic medications. And no, doctors do not get paid by pharmaceutical companies.
That's one thing.
Not now, not never. Stark Law, Sunshine Act, thank you very much, okay?
They're like, we're just a shill for big pharma. So
if they did, I would know about it, and they don't.
People think you get a check at the end of the month for prescribing statins. First of all, they cost like 2 pennies a month.
Like $2.
And the only one that's not generic is pitavastatin, and literally no one uses it because it's not that potent, and you would never use it anyways. Even if it was generic, I'd probably never use it. So regardless, people think that we are like out here telling you I mean, imagine, if you lived in the 1900s and somebody was like, one day we're going to be in these metal objects that drive us around and these airplanes that can fly you from continent to continent. And on your phone, you could do a Zoom meeting with somebody from China. People are like, I don't want that. I'm happy living in my dirt hole.
Yeah, right.
who on earth? Why do these people exist? I don't know.
Well, we're humans. We're designed to evolve. We're not like a bee that just does not evolve. It literally just stays a bee. We evolve into better things.
When you have a problem and you find a way to solve it, isn't that a good thing? Like, we could not drive. Like, it was hard to get around. We made cars, and we made airplanes, and we made internet. We made telephones. We have this thing that kills us called LDL cholesterol.
Yeah.
We can actually lower it now. And that eliminates 90% of why people die. It used to be in 1934, the number one cause of death in the United States, 90%, well, maybe not number one. It obviously is number one, but 94% of people used to die of heart disease in 1934.
And cardiology was not even a subset of medicine back then.
They would die and no one would really know why. People would just drop dead at 42, 45, 55, at the most. They were really short lifespans. People die. A lot of times they never. And then when we figured out the whole cholesterol thing in the 50s and 60s, it was like, there's this thing. But people still did not live long enough to where, autopsies made sense or what have you. Eventually we kind of figured it out. But until then, why are we still living with this thing that we can eliminate 100%? That to me makes no sense.
Absolutely. Absolutely. All right. Well, I think we debunked a lot of myths, and, I think we've really, explained a lot of, extrapolated on the cholesterol truths. And I want people to get the takeaway. The key takeaways are, your organs do not need circulating cholesterol to function. There is no such thing as too low LDL. You are not going to get dementia. Statins do not cause dementia. It's actually the opposite. And if just having a coronary artery calcium score of 0 and having high LDL is not sufficient enough, you are not out of the dark at all. You're actually still very in the dark. And, with modern medical therapies, we can optimize our cardiovascular function, our arterial health, our endothelial function. And, I brought the guy to really explain it, the author of Cholesterol Truths. Dr. Allo, thank you for joining us today.
Yeah, thanks for having me. It's been a pleasure. These are obviously topics that are super important that I don't think get enough airtime from actual experts who know the data inside out. So I appreciate you having me on and tackling this very complicated yet simple topic, and hopefully people will benefit from this and share it with others.
Stay strong and healthy.